there, I'm back talking with Dr. Holly. Dr. Holly, do you think you can tell us a little bit about how, as a physician advisor, you engage the treating physician?
Sure. So, as kind of an internal physician advisor for our group, one of the things we kind of try and do is not just provide reviews on cases, but try and provide some education towards our physicians around medical necessity, but also around documentation and just a lot of kind of rules to begin with. So what I found a lot is, as a internal PA, I have a big advantage in that I know most of the physicians. And so it's pretty easy in most cases when I review a case and have a question about what's going on, or I see something that doesn't necessarily add up, to get on the phone and call one of the other physicians in the hospitals who, again, most of the cases we know, and have a discussion about it. And we found that my partners in the hospital and other treating physicians are pretty open to receiving a phone call from one of our physician advisors, because they know it's another doctor that practices in the hospital. And again, they know most of us, and they're very willing to take that phone call and have that discussion. One of the things, seen is that physicians in general don't get training on medical necessity. They don't get training on utilization management. So in most cases, they kind of don't have a good understanding of it. And when that happens, they tend to be defensive about these things. So they're often defensive in phone calls with case managers or with external physician advisors, because they don't really understand things. We've kind of tried to set up a kind of a relationship with our docs where when we call them, it's very open and it's really a discussion, and we like to kind of think of our physician advisors as really kind of working for them and helping them kind of understand and do the things they need. And it's gotten to the point where we'll often get phone calls as an internal physician advisor from physicians for cases we weren't even reviewing, where they're just asking for our help. When they've got cases where they just feel like the status isn't correct, or they can't get to the right placement on a patient, they'll call our internal physician advisor and ask them what they can do better to document, or is there something different they should be trying, or just ask general questions about differences in payers and differences in status. And they really have gotten to the point where they use our internal physician advisors to kind of help them with all those type of questions. One of the ways we've gotten to that point is by being a local internal physician advisor. We're able to be at hospital committee meetings. We go to, obviously, the meetings. We're on hospital executive committees. We go to guidance councils, and we're able to bring up these issues with the other physicians at a lot of different meetings, and really have a lot of face-to-face discussions with physicians about these things. And I think they gain a lot more through those kind of face-to-face discussions, and they're a lot more willing to ask us questions about these scenarios when we're just kind of in the room having casual conversations about it. So I think there's that huge advantage of kind of being able to work with these physicians on a regular basis and have those relationships, so then we can get them more engaged.